think this is my third time coming in person, but I've participated virtually in almost all the AWE meetings over the almost past decade, and it's a pleasure and honor to be here and work with these ladies on a regular basis. So I was asked to talk about EUS guided gallbladder drainage. Here's my disclosures. You know, I think in 2026, everybody knows that the first line treatment for cholecystectomy in a suitable patient is cholecystectomy. But what about those patients that are not suitable surgical candidates? You know, what are our management options for non-operable candidates? And so we have percutaneous gallbladder drainage, ERCP with transpapillary cystic stent placement, and EUS with gallbladder drainage. And I'll kind of go through those techniques and what are some of the benefits and downsides to them. So with percutaneous gallbladder drainage, the great news is the GI doc doesn't have to be the one coming in on call for these emergent cases. Those are going to be interventional radiology, and it's widely available at most hospitals. It's pretty easy for the radiologist to access the gallbladder. The cons are patients have external drains, they have a lot of discomfort, those tubes can get obstructed, dislodged, have leakage around the site, and often need re-intervention. So not perfect, but easy to get. ERCP with transpapillary cystic duct stent placement. The pros are, if you're going in anyway to do an ERCP on someone who might have a bile duct stone or cholangitis, might as well give it a try and put a stent into the cystic duct to drain the gallbladder at the same time, and you kind of kill two birds with one stone. The cons are, if you have cholecystitis, you often have an obstructed cystic duct, and it's very tortuous in shape to begin with, so it may be hard to get your guide wires and stents and catheters across the cystic duct into the gallbladder, and often you do have stent migration. So then that brings us to EUS guided gallbladder drainage. You know, back in 2007, this technique was first described using double pigtail stents. Then years after that, people were using standard biliary metal stents. And then more recently, I think dating back for probably the past decade, we've been able to use lumen-opposing metal stents for this purpose. And you saw in Dr. Saviti's talk, you know, he already talked about LAMs a little bit, but the other metal stents are kind of too long, they can migrate, you have to do multiple steps to place them. But with cautery-enhanced LAMs, you know, everything can be done with one device, one quick step, no device exchanges, and you have different diameters and lengths of the stents. And in the US, we have 6, 8, 10, 15, and 20. I'll talk about some pros and cons with the different sizes for the gallbladder. Usually we use a little bit bigger stents. And again, you don't even need fluoroscopy. So if you had to do this emergently, say in the ICU bedside with just your EUS processor, you could do it in an emergent situation. And they are FDA approved now for gallbladder drainage in the US. There is no CPT code though, so that's where it gets a little tricky on billing. But I would say you always have to have a multidisciplinary discussion with your surgeons, because currently we're not placing it routinely in patients that will subsequently become surgical candidates. So this is an example of a distended gallbladder. You'll see the cautery-enhanced catheter go into the gallbladder. We advance it down as far as we can. Then you open up your distal flange, pull back, see this dumbbell or Hershey kiss shape. The inner catheter kind of moves superiorly towards that edge of the flange, and then you deploy your proximal flange inside the scope, just like you do for a pseudocyst. And that's why for endosonographers, the gallbladder is a nice target when it's distended, because it looks, and we treat it like a pseudocyst. There's different techniques. You can put an FNA needle, guide wire, and then your LAMs, or most of the time we do it freehand now. Most of the time 10 or 15 millimeter diameter stents in my practice, and then we can talk about placement either in the antrum or the duodenal bulb. And so I just mentioned a little bit, you know, cautery enhanced LAMs, that's probably the most popular choice because you can do it freehand. don't need fluoro or device exchanges. I usually put a 10 millimeter if there's no stones that I have to put my scope back in and go and treat later. If they do, then maybe 15. I don't think I've ever really done a 20 millimeter in the gallbladder because you don't always have that much room. And then there's debate, should you put a double pigtail through or not at the time of the initial placement, or do you switch it out later? But no clear benefit on that. Does the location of the lambs affect the outcomes? You know, from the antrum, you have better access to the body of the gallbladder, so it's a little bit larger target. But this was a case I had. You know, when you put it in the antrum, they are prone to stent occlusion from food, and because you have a lot of contractile forces there, you may have inward stent migration and a lot of tissue overgrowth, so then the patient comes back with recurrent cholecystitis. There is, you know, discussion with the surgeons, though, that say if you placed it in the antrum and then the patient went for cholecystectomy later, it's easier for the surgeons to close the defect in the stomach than it is the duodenum. The duodenal bulb, though, for the endoscopist is probably the more preferred location. You're going into the gallbladder neck, but it's a little bit more stable position for your stent deployment. But again, if the patient went for cholecystectomy later, that might be harder for the surgeons to close. But their studies have shown no real difference in outcomes between the locations. So I usually try to go for the bulb, but I go wherever the best target is. So if it's the antrum, it's going to be there. What do we do for follow-up? Most of the patients we're doing in our center are probably cancer patients, and we just leave the lambs indefinitely. But otherwise, you can repeat your endoscopy after a few weeks. Once your tract is matured, you can go in and clear stones using techniques we use at ERCP. And then at that point, you might switch out the lambs for a few pigtails that you leave in indefinitely. But right now, there is no standardized follow-up protocol. People kind of make it up at different centers as they go along. How does EUS guided gallbladder drainage compare to other techniques? You know, if you compare it to percutaneous gallbladder drainage, Anthony Teo, who's a surgeon out of Hong Kong, who's probably published the most on this topic in general, had a randomized controlled trial of EUS versus perc drains and showed that EUS guided gallbladder drainage had comparable efficacy to PT gallbladder drainage, but less reinterventions, lower adverse events, and better patient tolerance. What about EUS guided gallbladder drainage versus ERCP with cystic duct stenting? This was a meta-analysis, looked at 5 studies, almost 1,000 patients, and they showed that EUS gallbladder drainage had comparable adverse events, higher rates of technical and clinical success than cystic duct stenting, and less recurrent cholecystitis. So EUS gallbladder drainage comes out pretty good when you compare it to the other techniques. So when to think twice about doing a gallbladder drain? If the patient has a perforated gallbladder, already has peritonitis, on imaging you see intervening colon, then you're not going to do it. But relative contraindications, if the gallbladder is a little bit more distant from the GI tract lumen, depending on the scenario, you might be able to pull it up closer, but I'd be very cautious. If you have a really contracted gallbladder, it may be hard to reach and pull back. If you have intervening vessels, large volume ascites, some people will tap the patient and then do the procedure. If they're going for surgery later, or if they can't tolerate anesthesia. So these are all potential contraindications. So this is a case where I didn't follow any of my rules about not doing it, and I tried to do it, so it led to a complication. But you see a very contracted gallbladder. I don't know what this measurement is. It's kind of fake news because really the distance from the GI tract wall is way more than 1 centimeter. And then you see the cautery-enhanced lambs getting into the gallbladder, but I'm so far away from the wall. I can open the distal flange, but then when I start pulling back to bring the gallbladder up to the wall of in this case it was the stomach, there was so much tension that the proximal flange just deployed on its own without me doing anything. It just came out of the catheter. You see some pus, and it was just barely in the stomach. And I thought, let me just pull it in just a little bit more to make it perfect. And then I pulled it out of the gallbladder, and you'll be able to see peritoneum there. So I took it out, and then I put an over-the-scope clip to close the gastric defect. In this particular case, my surgeon said I'll try to do a cholecystectomy, but when he went to do it, unbeknownst to me or not appreciated, was that the gallbladder was like a rubber ball, and it was just tacked down by pancreatic cancer in this case, and even he couldn't remove it, so the patient just got a drain and did fine. But I think if you follow those kind of contraindications or relative contraindications, you can avoid doing this in the future. And, you know, a couple years ago, we published this clinical practice update by the AGA that gives you a little bit of an algorithm on when to consider EUS guided gallbladder drainage. You know, if the patient can't tolerate sedation, you're not going to do endoscopic drainage. If you have large volume ascites, or you're already going for an ERCP, go for ERCP-guided cystic duct stenting. Otherwise, EUS gallbladder drainage should kind of be something that you think about. Some other issues to consider, you know, can you perform EUS-guided gallbladder drainage after a percutaneous drain? It can be technically challenging, especially the longer or farther out you are from the perc drain placement, because the gallbladder gets contracted farther away from the GI tract wall, and it can get really fibrotic, so it may be harder to puncture. But, you know, if you use the drain to infuse saline or water, you can try to distend it again and can successfully internalize the drain. What about cholecystectomy after EUS-guided gallbladder drainage? Anecdotal evidence, you know, the surgeons will say there's going to be a lot of adhesions. If we're doing it laparoscopically, it may be hard to close the defect where the stent was, so they don't like us to do it if the patient will go to surgery later. So again, we're using it mainly in those inoperable candidates. And you may, if you think maybe they're going to go to surgery later, aim more for the stomach side, but very limited data. This was a retrospective study that looked at percutaneous versus EUS-guided gallbladder drainage in patients that subsequently underwent cholecystectomy, and they actually showed that the 11% of the cases were converted to open in the EUS-guided group, but 19% were converted to open in the percutaneous group. So their conclusion was that EUS-guided gallbladder drainage outperformed the percutaneous route prior to cholecystectomy. But again, this is retrospective, limited, so we still need to investigate this a little further. But you know, with more data, is cholecystectomy going to become obsolete and go the way of the bile duct, where endoscopists will take over? You know, I think before that would happen, we'd have to standardize our patient selection, how we do it, and the follow-up. The other problem is, you know, there's 1 million cholecystectomies done in the US every year, and there's not enough endosonographers to do that many EUS-guided drainages. And also, again, the late-night calls, and if we want to get into that business, is still to be decided. But Anthony Teo has been doing a study again in Hong Kong, where he's looked at patients who were operable candidates and followed them. Now it's been a few years, and I think he's going to publish the final results sometime within the next year, but showed that very few reinterventions or biliary events happened in the patients that underwent Lamb's drainage instead of cholecystectomy. So, you know, he's saying they could potentially be comparable. Something to think about. And just lastly, I'll talk about EUS-guided gallbladder drainage for malignant biliary obstruction. You know, this was a case, the patient had advanced pancreatic cancer. They already had a surgical GJ for duodenal obstruction. Now they have jaundice. CT shows biliary dilation. On EUS, you can see there's a dilated bile duct, but there's a lot of tumor in the duodenal wall. So the distance from the duodenal wall to the bile duct is more than 1 centimeter, so direct bile duct drainage is not an option, but they have a nice gallbladder. And again, you see the same technique I used earlier, where we go in with our cautery-enhanced lambs and deploy our stent, and by the next day, the bili came down by half. So this is definitely something to consider. And there were a bunch of retrospective studies that looked at this topic, and then this was in Endoscopy published this year, and they talked about using EUS guided gallbladder drainage as first-line therapy for malignant biliary obstruction. And again, when you look at the gallbladder in terms of size compared to just a dilated bile duct, it's a much bigger target. So for the endoscopist, again, we feel a little bit more comfortable draining the gallbladder in these situations. And right now in the US, the 6 and 8 millimeter lambs are off the market anyway, so you're left with the bigger stents. So we have been using this technique quite a bit in those patients where we're not getting transpapillary biliary drainage. So I'll just end with, hopefully I've proved to you that EUS-guided gallbladder drainage is a viable treatment option. So something to think about in non-operable candidates with cholecystitis and in those with malignant biliary obstruction. But you always want to choose your patients very carefully and have a multidisciplinary discussion with your patients. And if you guys want to come to Chicago when it's nice weather, we're doing Chicago Live August 21st. So thank you.